Hi everybody, Tim Emerson from Quanyan Healing. What is pain? You may be surprised. I know I was. When I was in school science class, I was taught that nerves under the skin sense pain, such as touching a hot stove, sent the signal to the brain, which then sent a signal to react, like pulling a hand away. But that's not the way it happens. We don't have pain receptors. Can you imagine that? That's actually true. We do not have pain receptors. Explains neuroscientist pain specialist Lorimer Moseley. Pain comes not from the region feeling it, but from the brain's evaluation of the danger, from the senses, expectations, previous exposure, cultural, social norms and beliefs, and how we feel about these. Pain, as defined by the International Association for the Study of Pain, is, quote, an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So pain is a localized emotion. Does that mean it's all in our heads? No. Danger detectors distributed across the body tissues act as the eyes of the brain. So here's what happens. In nociceptive pain, meaning in response to a stimuli, the pain is it's an early warning. The nerves have sensed temperature, vibration, stretching, oxygen starvation, or chemical changes from damaged cells, and send an early warning signal to the brain, which in turn starts the inflammatory response. This protects the area and sends in neutrophils to fight any infection, widening narrow blood vessels to increase blood flow and volume, which causes the swelling and the redness. But there's two problems. First, the inflammatory response also increases pain sensitivity. Yes, that means you feel pain more intensely than you did before the injury, an overreaction. And second, the mitochondria, the organelles that are responsible for cell digestion and respiration, are spilled from damaged cells, and then they are attacked by the neutrophils as invaders, actually setting up a needless second round of inflammatory response, and you guessed it, more pain sensitivity. In chronic pain, the true need for pain is distorted, and the pain self-perpetuating. The cause of these signals can be confusing as well. In somatic pain, the pain is sharp, localized, and hurts to touch. But visceral pain is a vague, deep ache. It's hard to localize, such as cramps or colic. Problems in the pelvis, abdomen, and thorax can manifest as lower, middle, or upper back pain, respectively. The pain itself can also be referred, such as a heart attack felt in the shoulders, back, or neck rather than the chest. To address pain caused by acute injury, we just turn off the danger detectors. This can mean medically treating the underlying cause, like antibiotics for an infection. When the brain feels it's safe, the pain will stop. Analgesics can be used to block the signals and hence the pain. But now we're back to the problems of taking these long term. Codeine, for example, can even increase pain sensitivity, and all analgesics can cause analgesic rebound, where the body's production of natural endorphins drops in response to analgesic use, increasing sensitivity to pain once again. Non-nociceptive pain is a whole another world. Here there's no outside stimulus, as the signal is coming from within the nervous system itself, whether between the nerves, between the tissues and the spinal cord, or between the spinal cord and the brain. The cause could be nerve degeneration, for example, stroke or multiple sclerosis or oxygen starvation. Could be a trapped nerve under pressure or disc problem. Could be nerve infections such as shingles or a nerve injury from a fracture or soft tissue injury. All signals that are misinterpreted as pain. This sympathetic pain can be intense. And the reasons to prevent use. That's what the brain is trying to do, right? But that in turn causes new problems like muscle wasting, osteoporosis, and stiffness in the joints because the new collagen is actually stiffer than the replaced collagen. It could even be pathological pain, which is an abnormal, amplified, malfunctioning, dysfunctional pain that includes fibromyalgia, irritable bowel syndrome, and some headaches. Neuropathic pain is responsible for both phantom limb pain, from the mild pins and needles to a constant and severe burning sensation, and for the extreme limb pain of complex regional pain syndrome after a seemingly small tissue insult like an insect bite or minor cut. But once pain becomes chronic, in conditions like lower back pain, rheumatoid arthritis, fibromyalgia, or cancer pain, treatment becomes really elusive. Pain not associated with an acute injury could be from any of a variety of factors: the immune system, endocrine system, movement tissues, cognition, or the very mechanism by which the brain represents the body. Sensitivity increases, the dark side of neuroplasticity. Negative emotions also increase pain, such as sadness, anxiety, dwelling on the pain, or simply poor job performance or satisfaction rather. Negative emotions are the result of chronic pain as well. Depression is common in chronic pain sufferers. Muscle knots, awkward posture, vitamin D deficiency, some of the drugs given for osteoporosis or Paget's disease, statins for lowering high blood cholesterol, all these can cause pain. Even an easy to identify complaint such as back pain could be from poor posture, from bad lifting, overweight, which is hard on the knees too, curved spine, a traumatic injury, high heels, a poor mattress, poor shoes, aging degeneration of the disease, diseases like rheumatoid arthritis, osteoarthritis, fibromyalgia, gallbladder, cancer, multiple sclerosis, stomach ulcers, AIDS. Psychological factors following physical healing, it's complex. So here's the thing. After your doctor has addressed the acute injury and offered analgesics if appropriate, imagine the immense and confusing task if the pain persists. So the doctors and their patients try things: massage, TENS units, anticonvulsants, antidepressants, acupuncture, meditation, chiropractic, osteopaths, biofeedback, low-impact exercise, stretching, physical therapy, cognitive behavior therapy. Fact is, they're doing their best, but they're guessing. In fact, Dr. Russell Portney, chair of pain medicine at Beth Israel Hospital and past president of the American Pain Society, says flat out, quote, "We don't have enough evidence from studies to know just which approach is right for which patient." WebMD adds, despite decades of research, chronic pain remains poorly understood and notoriously hard to control. A survey by the American Academy of Pain Medicine found that even comprehensive treatment helps, on average, only 58% of people with chronic pain. And even that means managing pain, not curing it. Pain and pain response varies from person to person, and with the same person from moment to moment. Dr. Moseley adds, any credible evidence that the body is in danger and protective behavior would be helpful will increase the likelihood and intensity of pain. He also adds, any credible evidence that the body is safe will decrease the likelihood and intensity of pain. It is as simple and as difficult as that. Well, if pain is all about perception, can we just use the placebo effect? Well, yes and no. That's what we'll talk about next time, so stay tuned. Hey, if you haven't got a copy yet of 10 mistakes that keep people from finding the healing they need, it's free. Click the link below and get more articles like this one. Take care for now.